আমরা এখানে মেডিকেল কলেজে AOI ওয়েস্ট বেঙ্গলের দিক থেকে যে ক্লিনিক্যাল মিটিং, we will start the program. First there will be a sponsored talk by Dr. Misbah. Dr. Misbah ul Haq, a senior resident attached at this institution at present. He will give his speech about the clinical approach to a patient with headache and otolaryngologist's perspective. After that, we will do a short inauguration. We will call our principal sir and MSV sir. Misbah, kindly come to the stage and give your talk. This is a sponsored talk. There will be no questions from this talk.
Hello, good afternoon everybody. Good afternoon respected judges, senior dignitaries and members of the audience. First of all, I would like to thank all of you to get some of your time out of your busy schedule to attend this clinical meet in this horrible weather. And I would like to thank AOIWB to give me this opportunity to speak today. Before I go to my talk, I would like to ask a small question. How many of you have heard this statement from the patients? Dr. Babu, amar sinus problem ache. Can I see some hands, please? Yeah. So I think majority of you have this thing. Patients usually come to us with a diagnosis in their mind that amar sinus problem ache, and they want you to treat with it. And what we do, we go for a one-dimensional approach. We think that probably it's a sinusitis. We think maybe this patient was referred to from a neurology, or maybe this patient wants to treat this, wants to get treated. So today I would like to debunk this. Today we would try to attempt a clinical approach towards headache from a perspective of an ENT surgeon. Now, headache can be a disease, it can be a symptom, it can be both. Usually patients who come to us in our outdoor, usually they present with some symptoms, and we think that this headache is probably due to sinusitis. But it might not be. It can be a primary in origin. Usually migraines are a disease of primary origin, right? So you can see here, 1 out of 4 to 1 out of 8 people in India present with migraine. That is 213 million people. But if you see chronic sinusitis, it is only 134 million. So the chances of a patient coming to you in your outdoor with a migraine is much more likely than chances of a patient coming with sinusitis. So headache is not just sinusitis. Headache is a vast term. It has so many subtypes. We need to identify each and every one of them, at least on the basic level. So the ICHD, or the International Classification of Headache Disorders, have classified headaches into various types. The first one is the primary headache disorders. We all know the first one is migraine. Second is tension type headache. Third is trigeminal autonomic cephalgias, out of which it has some subtypes: cluster headaches, paroxysmal hemicrania, short-lasting unilateral neuralgia form headache attacks, and hemicrania continua. The other primary headaches are some can be of short duration, which can be less than 4 hours, or it can be more than 4 hours. The characteristics, some of the triggers, maybe a patient can come to you with a headache after following a large cough. If he tries to expectorate, after that he might complain of headache. So it is not just a headache of sinusitis. Usually older people can come with hypnic headache. It is like an alarm clock headache which occurs usually at night, and it makes the patient wake up from the sleep. Secondary headache disorders. Now this is something which we usually encounter. The secondary headache, as we all know, it is probably due to some primary cause, and it can be due to trauma, it can be vascular cause like subarachnoid hemorrhage, it can be due to temporal cell arteritis, it can be non-vascular, usually due to neoplasms, it can be due to any substance abuse or withdrawal, it can be due to infection, and finally it can be due to diseases of ENT, which is what we are concerned about. So we don't want to stay in this box, we want to look at the whole bigger picture, right? So how to suspect these secondary headaches? Now there is a short mnemonic. If you remember SNOOP 4, you will be able to diagnose any kind of secondary headaches. SNOOP, S stands for systemic symptoms, N stands for neurologic symptoms, O is onset, another O is older, and P4 are positional, previous history, pregnancy, and precipitation by Valsalva. The other forms of headaches are pain attributed to a lesion or disease in the trigeminal nerve, occipital neuralgia, persistent idiopathic facial pain, and other headache disorders. Now, this is, I think, the most important slide in the whole presentation. I think this will pave a roadmap to the further slides. What to ask your patient? What will you ask your patient? So the first is sight. Batha kothai hoy? Is it unilateral? Is it bilateral? Is it in front of the head? Is it behind the eyes? Is it at the back of your head? Onset. When did it happen? Duration. So does it occur for few seconds? Does it occur for few hours? How long does it last? It can even last for months. What is the type of pain? Whether it is pulsatile, whether it is compressing. What is the intensity of the pain? Whether it is very severe. What is the diurnal variation? Whether it occurs more in the morning or more in the evening. Whether there are any aggravating or relieving symptoms. Whether there are any associative symptoms like nausea, vomiting, reduced sleep, photophobia, fever. Whether there is any past history of surgery or whether there is any long-term abuse. Now, having said that, we will try to analyze some of the cases through these parameters. So I'll come to the first case. A 25-year-old woman presented to the clinic to discuss symptoms of headache. Her headaches were gradual in onset, moderate left temple pulsating pain, severe over several hours, associated nausea, light sensitivity. She took some medications, did not go well, and the headache was usually more in the morning. So what can be the diagnosis? Anybody? It's migraine. So this ICHD, the International Classification of Headache Disorders, makes this criteria for migraine. And if you remember, if you remember the previous slide which I mentioned, all of the parameters will match here: unilateral, pulsatile, intensity, any aggravation, any associated factors. Each and everything you can diagnose if you know the criteria. So all those questions which I mentioned previously, if you ask your patient, you will come to a diagnosis. So this is the migraine without aura. The ICSD classifies migraine into 15 different types. We don't have the time for that. I'll just go through it. Migraine with aura is also known as the classical migraine. What is aura? Aura is something the patient will come and tell you, Dr. Babu, আমার যখন মাথা ব্যথা হয় তার আগে আমি বুঝতে পারি যে আমার মাথা ব্যথা হয়, মানে চোখের সামনে কিছু একটা চলে যায় বা কানে কিছু একটা আওয়াজ শুনতে পারি. So this is a sensory symptom which patient might come with, and then he goes with the headache. Now that headache can last for few minutes. That headache can last for few hours. The other type of migraines are chronic migraine, hemiplegic migraine, which can occur with a motor weakness, and migraine with brainstem aura. This is a particular concern to our ENT specialist because it is also a vestibular migraine. The symptoms can be vertigo, can be tinnitus, can be hypoacusis, can be diplopia. So we need to be careful about that. How do you treat acute migraine? First is a non-pharmacological treatment. So you can tell the patient to rest in dark place, hydrate the patient, ice packs. And pharmacological treatment will be paracetamol. Triptans are the first line of treatment, followed by ergotamines, codeine, and tramadol. How do you treat chronic migraine? There are so many medications. We don't use these medications usually in our day-to-day practice. So the consideration of ENT might be you can give amitriptyline, you can give nutritional supplements, and you can give beta blockers. But before giving beta blockers, I would advise you to do a ECG of the patient or even check the pulse before prescribing any beta blockers, because we don't know what the history, the patient might give you. Next, case 2. A 24-year-old female student pursuing MBBS presents with complaint of bilateral compressing headache since 3 years. Pain is occasional, mild to moderate with maximum intensity in the evening. Pain lasts from few minutes to few hours. She takes paracetamol as SOS, and there has been constant positive motivation on her by her parents to top her exams. There is no history of vomiting or photophobia. She has been having troubled sleep, especially before her semester exams. However, since past 3 months, she has been having frequent episodes of headache. Diagnosis? Correct. Tension type headache. So it can last from 30 minutes to 7 days. And it can be a bilateral headache. It will be a compressing type of headache. So if you ask the patient, mathar moddhe kichu ekta ki bhari jinish chepe boshe ache, patient will say yes, exactly like that. And the pain is usually at the end of the day. So it's more in the evening, and it is not aggravated by any routine physical activity. There are other types as well: infrequent variety, frequent variety, chronic, etc. So how do you treat? The first is non-pharmacological treatment. Psychobehavioral therapy has a grade A recommendation. Physical therapy, you can use the help of our physiotherapy colleagues and our psychiatric colleagues for a non-pharmacological treatment. For pharmacological treatment, the grade A advice is to give analgesics and NSAIDs followed with caffeine and selective COX-2 inhibitors. How do you prophylactically treat tension headache? You can give tricyclic antidepressants, alprazolam, etizolam, and you can give muscle relaxants as well. Coming to case 3, a 29-year-old man presented with past history of nondescript headaches that started around puberty. He described localized pain on either side of the head accompanied by anxiety, restlessness, and ipsilateral rhinorrhea and lacrimation. Attacks lasted for about 2 hours, regardless of whether he took ibuprofen or not. MRI was normal. Oral sumatriptan was helpful to manage the pain. Over the time, he noted that in spring and fall, he would have several weeks of daily attacks, occurring up to 3 times a day, and fade over the course for another few weeks. Oral sumatriptan eventually turned ineffective. He reported the pain on his right side attacks to be most intense in the eye, and the pain of his left-sided attacks most intense in his jaw. Any diagnosis? It's a cluster headache. I think a patient with a cluster headache, if he comes to you, he will actually beg to you to relieve his headache. He will literally cry in front of you that Dr. Babu, amar bathata komiye din. Now, if you see, the ICSD mentions that the severe or very severe unilateral orbital pain can last up to 180 minutes. So that is 3 hours. That's quite unimaginable, right? So you can see the other symptoms as well. Conjunctival injection, nasal congestion, eyelid edema. Now you do not confuse this with sinus headache. In sinus headache, there might be some symptoms, but you need to differentiate between a sinus headache and a cluster headache. And especially these cluster headaches, these occur in a series of events. Patients will have a symptom-free period, and then it will occur at the same time in the very same year, next year. So how do you treat cluster headache? Very simple. You give a nasal spray of sumatriptan. We can give a nasal spray, we can do a ENT examination, and we can give subcutaneous sumatriptan or zolmitriptan nasal spray, and it works quite well. There are some other types of cluster headache as well. Not types, I would say. The variation depends on the attack duration. If the duration is 2 to 30 minutes, it's paroxysmal hemicrania. The treatment line would change. You have to give indomethacin to the patient. And if the patient has a short-lasting unilateral neuralgiform headache, you can see the attack duration is up to 600 seconds only. So their anti-epileptics would work. Second last case, a 63-year-old woman initially presented with 2 years of electric shock-like pain that started just in front of her left ear and radiated into her upper teeth and cheek, triggered by lightly touching her face, a cool breeze on her face, chewing and brushing her teeth. At each attack lasted for only seconds, but frequently occurred in clusters, such as when eating a meal. What is the diagnosis? Correct. So trigeminal neuralgia, the ICSD mentions that the trigeminal neuralgia will have a recurrent paroxysms of unilateral facial pain in distribution of 1 or more divisions of trigeminal nerve, and the pain has to last from a fraction from a second to 2 months. It has to be severe in intensity, electric shock-like, shooting, stabbing, or sharp in quality. And it can be precipitated by innocuous stimuli within the affected trigeminal distribution. Classic trigeminal neuralgia is something which can be demonstrated on MRI or during surgery of neurovascular decompression, but not simply on contact, with morphological, obviously, changes in the cranial nerve root. There are some conditions which mimic trigeminal neuralgia. Some ENT considerations would be a temporomandibular joint disorder, where the pain will be aggravated by opening mouth. Some conditions will be first bite syndrome, where the pain will be on salivation. Some conditions would be a glossopharyngeal neuralgia, where the pain will be during swallowing or yawning. And some might be due to great auricular neuralgia while turning the head. How do you treat trigeminal neuralgia? Medical treatment is carbamazepine, oxcarbamazepine, and rescue treatment goes for nasal sumatriptan again. Surgical treatment, now here we have some role. We can give some peripheral nerve blocks in the supraorbital, infraorbital, auriculotemporal, mental areas. We can go for microvascular decompression, neuroablative procedures, stereotactic radiosurgery, and some percutaneous procedures as well. And the last case, a 73-year-old woman presented with a 7-month of history of sharp electric shock-like shooting pain in her left throat and deep into her left ear. The pain was triggered by swallowing and yawning, but talking, chewing, and touching face did not affect the pain. The back of the throat felt very sensitive and so tender that she could not eat. At local clinic, an otolaryngologist performed a topical lidocaine block over pharyngeal region, which provided significant relief. She also had a hard palpable mass around the lateral neck, which she had been noticing since past 2 months, and MRI suggested findings of tonsillar carcinoma. So what kind of pain is this? Glossopharyngeal neuralgia. So it's a unilateral paroxysmal electric shock-like pain affecting the posterior tongue, pharynx, tonsillar fossa, deep in the ear or beneath the angle of the jaw. Attack can last from 2 seconds to 2 minutes on an average. 2% of patients can even have syncope. Similar to trigeminal neuralgia, glossopharyngeal neuralgia can also be caused by neurovascular compression of the glossopharyngeal vagal complex. Secondary causes of glossopharyngeal neuralgia would be some skull-based tumors, Eagle syndrome, and treatment is exactly similar to trigeminal neuralgia. So if a patient is admitted in your ward with a tonsillar carcinoma and the patient complains to you with pain, don't give paracetamol, it won't work. And finally, the prodigal son of ENT, for which we treat headaches, is due to acute rhinosinusitis. What does the EPOS 2020 guidelines say? It says that it has to have an inflammation of nose and paranasal sinus characterized by 2 or more symptoms. One of has to be nasal blockage, obstruction, congestion or nasal discharge, followed by either facial pain or pressure, or anosmia or hyposmia in adults, and cough in children, along with endoscopic and CT signs, obviously. And what does the ICSD say? As the ICSD says, if your sinusitis is more, your headache will be more. If your sinusitis is less, your headache will be less. And headache will be exacerbated by pressure applied over paranasal sinuses. And this is the treatment of rhinosinusitis, we all know, so I'm not going into much detail about this. So finally, what do we learn from this? First is, we need to debunk patient's self-diagnosis. We need to tell the patient that whatever you're thinking, that might not be true. Second is, detailed history is imperative even if the case is referred to you. So even if a case is referred to you by neurology, start from the basics. Patients may have more than one type of headache interlapping each other. So don't just think about only one diagnosis. Patients can come with migraine and sinus headache together. Question your diagnosis. So if once you have determined your diagnosis, think again. Can it be something else? Avoid jumping to conclusions. Take a step ahead in treating headaches not associated with sinusitis. And finally, if you are unsure about the diagnosis or if the treatment is refractory, neurological opinion is always an option for you. That's all from my side. I thank you all for being a lovely audience. And I must thank the patients, irrespective of what they say. We learn from them, and we'll always continue to learn. Thank you so much.
Thank you, Misbah, for your excellent presentation. এখন আমরা একটা ছোট ইনগ্রেশন করব। আমি আমাদের প্রিন্সিপাল স্যার প্রফেসর রঘুনাথ মিশ্র স্যারকে একটু স্টেজে আসার জন্য ইনভাইট করছি। আর তার সঙ্গে আমাদের এমএসভিপি স্যার অঞ্জন স্যার, আর আমাদের ডেপুটি সুপার স্যার ডক্টর জয়ন্ত সান্যাল স্যার। তিয়াশা চলে স্যার, আসুন স্যার, মাঝখানে বসুন। আমাদের প্রফেসর অ্যান্ড এইচওডি ডক্টর সৌমেন্দ্রনাথ বন্দ্যোপাধ্যায় স্যার, আমাদের প্রেসিডেন্ট এওআই ওয়েস্ট বেঙ্গল হারাধন বোরা স্যার, আর এক্স প্রেসিডেন্ট শুভজিৎ ব্যানার্জি স্যারকেও ইনভাইট করছি স্টেজে আসার জন্য। জয়ন্ত দা চলে বসে পড়ে। সোমেন স্যার, আপনি এদিকে চলে আসুন। হ্যাঁ হ্যাঁ, আমাদের প্রফেসর ডক্টর রামানুজ সিনহা স্যারকে আমি ইনভাইট করছি স্টেজে আসার জন্য। আপনি এখানে বসুন সোমেন স্যার। আমাদের জুনিয়র রেসিডেন্ট তিয়াশাকে বলছি যে আমাদের প্রিন্সিপাল স্যারকে ছোট ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবার জন্য। আমি দিব্যাকে বলছি আমাদের এমএসভিপি স্যারকে ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবার জন্য। পরমাকে বলছি আমাদের ডেপুটি সুপার স্যার জয়ন্ত সান্যাল স্যারকে ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবার জন্য। পরমা। আমাদের এওআই ওয়েস্ট বেঙ্গলের প্রেসিডেন্ট ডক্টর হারাধন বোরা স্যারকে ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবেন সুতার্থী। আমাদের এক্স প্রেসিডেন্ট ডক্টর শুভজিৎ ব্যানার্জিকে ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবেন তিয়াশা। আমাদের প্রফেসর ডক্টর রামানুজ সিনহা স্যারকে ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবেন দিব্যা। আর প্রফেসর সৌমেন ব্যানার্জি স্যারকে পরমা ফ্লাওয়ার স্টিক দিয়ে অভ্যর্থনা জানাবেন। আমাদের এওআই ওয়েস্ট বেঙ্গলের যে ক্লিনিক্যাল মিটিং আমরা মেডিকেল কলেজে করতে পারছি, তার জন্য আমরা থ্যাঙ্কস টু এওআই ওয়েস্ট বেঙ্গল ব্রাঞ্চ। আমি জাস্ট প্রিন্সিপাল স্যারকে ছোট করে যে এখানে আমাদের ক্লিনিক্যাল মিটিং হচ্ছে, স্যার যদি কিছু একটু বলেন।
নমস্কার। আজকের এই দিনটা বর্ষা ভেজা দিন অটোলেরিঞ্জোলজিস্টের। আজকের এই শুভ অনুষ্ঠান যে মাসে মাসে যেটা হয় যা জানলাম, এবং এই রকম আমি 5টি কেস প্রেজেন্টেশন দেখলাম খুব সুন্দরভাবে, এবং এতে আমাদেরও, আমরা যারা এখন ইএনটির ক্ষেত্রে আমরা হচ্ছি লেম্যান দিককেও কিন্তু খুব সহজভাবে মানে আমাদের স্পিকার বা যিনি প্রেজেন্ট করলেন খুব সুন্দরভাবে বুঝিয়ে দিলেন। তো এই রকম প্রেজেন্টেশন যদি মাসে মাসে সত্যিকারই হয়, প্রতিটি পিজিটি বা যারা আমরা মানে অন্যান্য স্ট্রিমেও আছি তারাও অনেকটা উপকৃত হব, এবং অ্যাসোসিয়েশন অফ অটোলেরিঞ্জোলজিস্ট তারা তো উপকৃত হবেনই। তো এটা একটা খুব ভালো উদ্যোগ, এবং এইভাবে আমি একটা কি দুটোতে বোধ হয় প্রেজেন্ট ছিলাম, মানে আইপিজিএমআর এসএসকেএম, কিন্তু এখানে আজকেই প্রথম হলো, হয়তো অনেক দিন পর হলো। তো এখানে দেখতে পাচ্ছি যে আমাদের সামনে যারা বসে আছেন তারা আমাদের থেকে অনেকেই অনেক সিনিয়র, এবং তারা এই ফিল্ডের তো অবশ্যই, এবং অন্যান্য ফিল্ডেও তারা অনেক নামকরা ব্যক্তিত্ব, এবং আমাদের যারা এখানে আছেন তারা তো সবাই নামকরা ব্যক্তিত্বই এখানে মঞ্চে উপবিষ্ট হয়ে আছেন। আমার ডান দিকেই বসে আছেন আমাদের এমএসভিপি, যিনি সদ্য এখানে এসেছেন, এবং উনি একাডেমিক পার্সন একজন, এবং আমাদের এখানে এই হাসপাতালের হাল ধরে আমরা আরও এগিয়ে নিয়ে যাব একসঙ্গে ভাবছি। সঙ্গে আছেন ইএনটির হেড, তিনি কর্মতৎপর সবসময়, এবং আমাদের এক্স প্রিন্সিপাল এবং এখানকার ইএনটির অধ্যাপক ডাক্তার রামানুজ সিনহা আছেন। এদিকে আমাদের ডেপুটি সুপারিনটেন্ডেন্ট আছেন, এবং আমাদের এখানে ইএনটি স্পেশালিস্ট যারা সমস্ত এখানের প্রাক্তন বা বর্তমান সভাপতি আছেন। তো আমি সবাইকে আমার শ্রদ্ধা জানাই, এবং আপনাদের এই প্রোগ্রাম খুব সুন্দরভাবে হোক, চলতে থাকুক বছরের পর বছর, যাতে মাসে মাসে এই ক্লিনিক্যাল মিটিং এবং উপকৃত হয় সমস্ত স্পেশালিস্টরা, এবং তার সঙ্গে সঙ্গে আমরাও কিছু যারা বাইরের লোক এই ইএনটির থেকে বাইরে, তারাও কিন্তু শুনলে অনেক উপকৃত হব। সবাইকে ধন্যবাদ, সবাই ভালো থাকুন, আপনাদের এই উদ্যোগ সফল হোক। থ্যাংক ইউ।
আমি এমএসবিবি স্যারকে ছোট করে কিছু একটু বলতে বলবো।
Most respected principal sir, respected other teachers, colleagues, friends and beloved students. First I must convey my thanks to the organizer, the society, for inviting me to appear in this program. খুব অল্প দিন হলো আমি দায়িত্বভার নিয়েছি আর কি। খুব ভালো উদ্যোগ, এগিয়ে যাওয়ার জন্য তো ভীষণ প্রয়োজন। শুধু একটাই রিকোয়েস্ট আর কি, যেহেতু সবাই তো মোটামুটি শিক্ষা জগতের লোক, কম্পিটেন্সি না ডেভেলপ করলে ইট উইল বি অফ নো ইউজ। Competency, competency and competence, and that competency must be supported by knowledge and affection. So all meeting, all আর একটা জিনিস হচ্ছে ডকুমেন্টেশন, আমাদের যেটা সিভিয়ারলি ল্যাকিং। মেডিকেল কলেজে কটা সিএমই হয় কেউ বলতে পারবে না, হয়তো হয়ে যাচ্ছে প্রতি সপ্তাহে একটা করে। মেডিকেল কলেজে কতগুলো এক্সপোজার হয় টিচিং লার্নিংয়ের, আমরা এনএমসিএলে উত্তর দিতে পারবো না। ফলে ডকুমেন্টেশন ইজ ভেরি ইম্পর্ট্যান্ট and a meaningful learning. Adult learning, all are adults, সময় নষ্ট করে লার্নিং। So learning must be purposeful and learning must be effective and meaningful, যেন কিছু টেক হোম নিয়ে যেতে পারি, যাতে ভবিষ্যতে আমার কানটা সুরক্ষিত থাকে। আমি আমার সুবিধা দিয়ে বলছি আর কি, আমি তো আমাকে নিয়েই বেশি ভাববো, আমার নাক ঠিক থাকে, আমার এগুলো যেন কম্পিটেন্ট লোকের কাছে গেলেই আমি নিশ্চিন্তে বাড়ি ফিরতে পারি আর কি। দিস ইজ অনলি রিকোয়েস্ট অ্যান্ড আই মাস্ট এক্সপ্রেস দ্যাট ইউ মে প্রসিড। আমি শুনছিলাম আপনাদের জার্নাল আছে, জার্নালটা ইন্ডেক্স জার্নাল, ভীষণ ভালো খবর আর কি, যে জার্নালটা ইন্ডেক্স হয়েছে এবং এনএমসি ক্রাইটেরিয়ার মধ্যে আছে। সুতরাং আরও জার্নালের শ্রীবৃদ্ধি হোক অর্গানাইজেশনের সাথে, আরও নতুন প্রতিভা উঠে আসুক আগামী দিনে যারা দেশকে চালাবে, নতুন দিশা দেবে, অ্যান্ড অবভিয়াসলি উইথ ইনোভেশন, নিউ ইনোভেশন আমাদের খুব ল্যাকিং একদম, যে পশ্চিমবঙ্গের অবস্থা তো আরও ল্যাকিং। আপনারা যদি বাইরের ইনস্টিটিউটগুলোতে যান, রিসার্চ ইজ অ্যান ইন্টিগ্রাল পার্ট দেয়ার অ্যাজ teaching, learning or education. So I may request all my respected teachers here to take this issue in its applied mode so that all of us can be benefited. Thank you. Bhalo thakben shobai.
Now I would request our very beloved Deputy Superintendent Dr. Sannal to say a few words of encouragement to us.
গুড আফটারনুন, উপস্থিত সবাইকে এখানে আসার জন্য অভিনন্দন জানাচ্ছি। আজ অ্যাকচুয়ালি বোঝা যাচ্ছে করোনাটা যে কমে যাচ্ছে বোঝা যাচ্ছে। আজকে দুটো অফলাইন প্রোগ্রাম একদিনেই হচ্ছে, পেডিয়াট্রিক্সও একটা হলো হচ্ছে, এবং এরকম প্রোগ্রাম যত হয় ততই ভালো এবং আশা করি ভবিষ্যতেও হবে। প্রোগ্রামের সাফল্য কামনা করছি এবং সবাই ভালো থাকবেন।
Thank you, sir. Now I would request our President, Professor Haradhan Bora, to deliver his speech.
It is my great pleasure to present in the and to welcome you all, and very good afternoon to all the participants of the clinical meeting and the members of the association. I convey my heartfelt thanks to Principal Middle College, Calcutta, Dr. Raghunath Mishra, the Superintendent, that is MSVP, Dr. Anjan Odhikari, and Deputy Superintendent Dr. Jayanto Sannal, and also HOD of and Department of ENT, Dr. Soumendra Bandyopadhyay, and the other faculty member and all the doctors of the Middle College Hospital, Calcutta. And I also like to say this clinical meeting will enrich our knowledge, and also we can exchange our some knowledge each and other, and so that we can go in the future in a very smooth way. Thank you all.
এবার আমি সৌমেন্দ্রনাথ বন্দ্যোপাধ্যায় স্যার আমাদের হেডকে কিছু বলে প্রোগ্রাম তারপর আমরা স্টার্ট করব। স্যার বলুন।
I welcome you all to the third monthly clinical meeting of Association of Otolaryngologists of India, West Bengal. We at Medical College feel humbled to have the opportunity to host the monthly clinical meeting in our college, and we have got all the support from the administration, the principal, the MSVP, the superintendent, deputy superintendent, all are present here, and we have got all the necessary support from our staff also. So I, on behalf of AOI West Bengal, welcome you to this clinical meeting. Already we have one presentation, beautiful presentation from Dr. Misbahul Haq on different types of headache. Hope the next presentations will also open up vistas of deliberations, and everybody will return enriched after this session. So with my gratitude and respect to all the senior dignitaries, I would request Dr. Mukherjee to start the presentations.
Thank you,
all.
sir. Now I will ask the first speaker, Dr. Shrutirtho Saha. Our judges for this session will be our President, Dr. Haradhan Bora sir, Sir, please take your seat. Our ex-president, Dr. Shubhajit Banerjee, sir, please take your seat. And Dr. Bidhan Rai. Dr. Bidhan Rai is at present the medical superintendent and vice principal of IKEA Hospital at Holdia. I will ask Tiyasha come and with a flower bouquet stick. bolchi dara age. And come with a flower stick and felicitate Dr. Bidhan Rai, sir.
All the speakers have 8 minutes time. There will be one bell at the 7 minutes, and then final bell will be at 8 minutes. You have to finish your presentation by 8 minutes. Then judges will ask the questions, and on that basis you will be given the scores. Okay. And the audience, it will be open for audience at the end of the program. So every speaker, then you will discuss the topics after the end of all presentations. And also there is one announcement that registration for our 13th MidwiCon, which will be organized on 20th and 21st August of 2022. The registrations is going on, and there is our staff is there. You can go to him and start the registration. Okay.
So good morning, respected judges, my respected faculties, my senior colleagues and my colleagues. So today I'm going to present a comparison between midline and lateral backdoor approach for thyroidectomy, a retrospective study. So introducing this study, right from the beginning we know the surgical techniques to remove a diseased thyroid gland have undergone a number of changes. Now conventionally, we approach the thyroid via midline, retracting the strap muscles laterally. But sometimes the strap muscles have to be cut to address enlarged glands with significant paraesophageal and retroesophageal extension. However, the lateral approach thyroid surgery, it allows to access to an enlarged lobe in the window between the sternocleidomastoid and the strap muscles, also access to the superior pole, the vital structures like the recurrent laryngeal nerve, the superior and inferior parathyroids is greatly enhanced. Especially in completion thyroidectomies, dissection of the nerves and the vessels is more difficult. Lateral approach provides a feasible technique for this purpose. So what are the aims and objectives of our study? Number one was to understand the nuances of lateral backdoor approach of thyroid surgery, and number two, to compare the results between midline and lateral approach thyroid surgery. So what are the methods that we followed? It was a retrospective cross-sectional study taking 15 patients as samples, conducted in a tertiary medical college from March 2022 to May 2022. Now 10 patients underwent midline approach thyroidectomy, whereas 5 patients underwent lateral approach thyroidectomy. All patients underwent routine preoperative workup like the ultrasonography, fine needle aspiration. Contrast enhanced CT scan was done in patients with suspected retrosternal extension and tracheal compression and invasion. Thyroid function tests was done, preoperative fiber optic laryngoscopy was done, and preoperative serum calcium levels were also estimated in all the patients. Now focusing on the lateral approach, a smaller transverse neck crease incision is made, extending from midline to the posterior border of sternocleidomastoid of the ipsilateral side. After raising the subplatysmal flap above and below, we dissect the anterior border of the sternocleidomastoid and skeletonize it. And now we enter the pocket between the sternocleidomastoid and the strap muscles. Here we can see we are entering the paracarotid gutter with the sternocleidomastoid retracted laterally and the strap muscle retracted medially. We can also see the external branch of the superior laryngeal nerve is dissected carefully and is preserved beautifully, and the superior pole which is present over here. Now after this, we can see this picture where we are seeing this tortuous vessel, the superior thyroid artery, the external branch of the superior laryngeal nerve lying over here, and the superior parathyroid gland is present here. This is a short video which is showing the carotid. This is the common carotid artery. This is the superior parathyroid gland. After that, what we'll be seeing is this tortuous vessel, this superior thyroid artery, which will be supplying the superior pole. Now, after medial traction of the gland, we approach the superior parathyroid glands, the recurrent laryngeal nerve, the inferior parathyroid glands, and the inferior thyroid artery and the middle thyroid vein. We have to ligate all the structure, the middle thyroid vein and the inferior thyroid artery. We have to preserve the superior and the inferior parathyroid glands, and we have to remove the gland and the pocket that we deliver. The result is this. So this is the recurrent laryngeal nerve. We can see the bifurcation of recurrent laryngeal nerve, and over here is the cricothyroid muscle that we can see. So after the removal of the thyroid gland, we can see there is a pocket between the strap muscles over here and the omohyoid and the sternocleidomastoid. So this pocket is kept open before we close the wound in layers. This is another picture showing the pocket between the strap muscles, the sternocleidomastoid, the recurrent laryngeal nerve, and the trachea are seen in midline. This is another video where we can see that the strap muscles are retracted laterally. We can see the superior parathyroid, the inferior parathyroid, the recurrent laryngeal nerve over here, and the trachea and the strap muscles are lying in midline. So what are the results? The results, obviously, we studied the parameters like the time of surgery first, then post-operative complications, blood collection in drains, and mean hospital stay of patients after surgery. So 7 patients underwent completion thyroidectomy, 2 patients underwent total thyroidectomy, and 1 patient underwent hemithyroidectomy. Whereas in lateral approach, 3 patients underwent completion thyroidectomy, and 2 patients underwent hemithyroidectomy. Mean operative time in midline approach was 2 hours 33 minutes, whereas in lateral approach it was only 2 hours. As we can see from this graph, which shows the orange line lying superior to the blue line. The orange line is depicting the hours taken to perform a midline approach thyroid surgery compared to the blue line, which depicts the time taken to do the lateral approach thyroid surgery. Analyzing the complications between lateral and the midline approach, we can see that in the midline approach, this tall blue line here depicts the temporary recurrent laryngeal nerve palsy following surgery, and the adjacent red bar depicts temporary hypocalcemia that developed in patients following midline approach. However, rest of the 40% of patients did not develop any complication. Whereas complications following lateral approach, if we see that 80% of patients did not have any complication, only 20% denoted by the small red bar, that was the temporary hypocalcemia following lateral approach thyroid surgery. Now 9 patients were given drain in midline approach and 3 patients were given drain in lateral approach. Now mean drain collection was measured after 24 hours. We saw that in midline approach, 20 ml was the collection, and in lateral approach, it was only 12 ml. We also assessed the mean hospital stay after surgery. Mean hospital stay after midline approach, it was 4 days, and mean hospital stay after lateral approach, it was 2 days. Now, after the results and analyzing the results, we come to the discussions lastly. We know that we surgeons are constantly trying hard and hard to make thyroid surgery better, safer, effective, improving the life of patients. Now, one advantage of lateral approach is we are preserving the strap muscles. We are preserving the integrity of strap muscles. In midline approach, if strap muscles are not severed, gland has to be retracted to expose the superior pole. As a result of this, the external branch of superior laryngeal nerve can undergo tractional injuries. Whereas in lateral approach, direct visualization of the superior pole is possible. With minimal traction of the gland, EBSL and injury risks become minimal. Also, I have discussed that we keep the pocket between sternomastoid and the strap muscles open. So life-threatening hematoma after surgery can be prevented. In redo surgeries, approaching midline is difficult because of presence of adhesions. And that's why lateral bacterial approach provides a better access to get direct visualization of the vital structures like the superior and inferior parathyroids and recurrent laryngeal nerve. And lastly, it is especially important while dealing glands via endoscopic transaxillary approach. So more experience in lateral approach can make the future of thyroid surgery via the endoscopic approach brighter. Now there are certain caveats of my study. The study was taken with small number of samples, only 15. Number 2, the 2 groups, that is the lateral versus the midline approach, take into account a different number of cases, that is 10 and 5. And the patients with bilateral thyroid pathology were not included in the study, and there is time constraint. So with this, I rest my case. Thank you so much.
Thank you, Sudipto. for your excellent presentation. Can you name the strap muscles? Because you have uttered strap muscle quite a few times.
Sir,
Just name of the strap muscles.
Sir, sternohyoid, sternothyroid, and thyrohyoid muscles.
And another one?
Thyrohyoid.
Sternothyroid, sternohyoid.
Yes, sir.
Another one?
Thyrohyoid, sir.
There is another one also. There is the most superficial part. Okay. Okay. Now, coming to the lateral approach, what is the potential risk? There is this approach has a potential risk. I think it should be in an experienced hand actually, this type of thyroidectomy, most likely.
Sir, number one risk is we are directly accessing the thyroid via this approach, so the great vessels, the common carotid and the internal jugular vein is very near. And also if you are dealing a gland on the left side, chances of injury to the thoracic duct can be a possibility. So chyle leak following surgery can be a possibility after this lateral approach, especially when addressing the glands on the left side, large glands on the left side, sir.
On the left side?
Yes, sir.
Okay. Have you heard the name of sympathetic chain?
Yes, sir, sympathetic chain.
Okay.
Dr. Sudipta Shah, you have a respective study of 15 cases.
Yes, sir.
Of which a group underwent lateral backdoor approach and another group underwent medial approach. Both the midline approach. Both the groups has redo surgeries and fresh surgeries.
Yes, sir.
Yes. But you have mentioned the time on an average. Did you find any difference between the time of surgery in each approach between the redo and fresh cases?
Yes, sir.
Just go to your slide.
Yes, sir, this one. So actually we can see that this first case, this is what I have plotted based on case-to-case basis. So if we see the first case over here, 2.5 hours, and this third case, it is 2.5 hours in the midline approach. The orange line is midline approach. So yes, there was some amount of overlap. Some in certain cases it did take 2.5 hours in midline approach.
Okay, how do you ligate the inferior thyroid artery in lateral backdoor approach?
Sir,
I think you were present in some of the operations.
Yes, sir.
It's not only a retrospective study of the case documentations. How do you ligate the inferior thyroid artery in lateral backdoor approach?
So we ligate the inferior thyroid artery close to the gland so that we can preserve the vessel which supplies the parathyroid glands, sir.
Very simply for that we need again the medial approach.
Medial approach.
Midline approach.
Yes, sir.
Okay.
Yes.
So lateral backdoor approach needs midline approach to ligate the inferior thyroid artery.
Yes.
And where do you transect or bisect the strap muscles? At what level? Upper level or lower level? Do you have any idea? Because different books has said different criteria. Someone said we have to transect it at a low level. Someone said we have to transect it at higher level. What you did in your cases?
Sir, in midline approach, we split the strap muscles along the linea alba coli at the lower level, sir.
Lower level. Can you explain the reason?
So reason is because we the upper attachment, hyoid bone, the attachment, also the blood vessels are over there. So we want to have a...
Now what do you consider when we are transecting a strap muscle? We consider the nerve supply through the ansa cervicalis.
Ansa cervicalis, that is in the upper part of the strap muscles.
So you transected all in the lower levels?
Yes, sir.
Okay, thank you.
Our next speaker is Dr. Madhurima Mondol, and her topic is orbital complications of face. Dr. Mondol, please.
Good afternoon, respected judges, and good afternoon, everyone. Today I am going to present orbital complications in face, our experience at a tertiary care center. So, functional endoscopic sinus surgery, it aims to restore the mucociliary function of all paranasal sinus and restore their ventilation and give proper drainage. And paranasal sinus and orbit, they are closely related anatomically. So the risk of injury depends on the some factors like anatomical variations, surgeon's experience, severity of the disease, or is there any previous surgical history. So there are some common orbital complications of face like orbital hematoma injury to lamina papyracea, subcutaneous emphysema, nasolacrimal duct injury, diplopia, blindness. So aim of our study was to evaluate the ocular complications after face in patients with paranasal sinus disease in a tertiary care hospital. Inclusion criteria was patients present with chronic rhinosinusitis planned for face, and exclusion criteria were patients with CRS with orbital complications, those who are not fit for surgery, patients with CRS having intracranial extension of the disease. Type of study was a retrospective study, place of study, inpatient ENT department, study population, patients are admitted for face, and my sample size was 102. Study duration was January 2014 to July 2017. So ophthalmic complications, they were divided into 3 categories like grade 1, grade 2, 3. Grade 1 is under minor category, injury to lamina papyracea and periorbital ecchymosis. Grade 2 or major category like lacrimal duct injury. Grade 3 or serious injury like retroorbital hematoma, injury to optic nerve or orbital muscle injury. So we had studied on 102 patients, and we found that in 12 patients we found orbital complications in 12 patients. Majority of the patients, number of cases were from the minor injury. Our number of cases were 7, and 1 patient found came from major injury, and 4 patients from severe injury. This is a pie chart. We can see that the most of the patients were present with minor injury. So we had compared our study with Bardak MS et al. Study. So in our study, the rate of the minor complication and also the severe complication is higher more than this previous study. This is a picture of periorbital ecchymosis with emphysema, and this sided picture is intraorbital hematoma. Come to discussion. Though incidence of ocular complication following face is very low, but it could be very dangerous and can lead to permanent visual loss. In our study, the ocular complication rate was 11.2%. We found 2 cases of injury to lamina papyracea. Total 7 cases were there. Out of them, 5 cases we found during ethmoidectomy, 2 such cases found during frontal sinus surgery, and we did conservative management and follow up the patients. We found 1 case with nasolacrimal duct injury when we are doing uncinectomy. So we did conservative treatment and do repeated syringing, and they still are in follow-up period. We found 2 cases during ethmoidectomy, and there was anterior ethmoidal artery injury, and we have to found emergency lateral cantholysis and canthotomy. This is a video of showing injury to orbit or injury to lamina papyracea where we are doing anterior ethmoidectomy. There is a orbital fat protrusion accidentally. In various studies, optic nerve injury was found to be around 0.12%, but in our study the rate was 0.98%. Here the cause of optic nerve injury was direct damage by surgical instrument, but direct optic nerve injury rate is very rare. We found 1 case of medial rectus muscle injury, and we gave conservative management. So post-operative complications depends on the detailed preoperative assessment, surgeon experience, severity of disease, using of powered instruments, primary or repeat surgery, any presence of coexisting comorbidity. Rene et al. Have suggested that eyes should be kept uncovered and monitored during the phase to see any movement resulting from the orbital fat traction. So incidence of orbital complications following endoscopic sinus surgery are rare, but it can be potentially very dangerous. We have to take some preventive measures like detailed preoperative evaluation. We have to look we have to use a new surgical device and proper surgical training. Surgeons should have proper knowledge about the detailed anatomy. Those are my references.
Thank you, Dr. Madhurima. You have mentioned proper anatomical knowledge of a surgeon. What is the commonest ocular muscle which is, injured, and why?
Medial rectus muscle, because during doing posterior rhythmoidectomy, it lies more close to the lamina papyracea. There is no such periorbital fat covering.
Have you heard the name of strabismus?
Strabismus. Yes,
What is it? Okay.
Sir,
In which year you are belong to? Which year?
third year.
Your study period is 2014 to 2017.
Because it was a retrospective study. I had
You
collected
should
all those
see
data.
This is a retrospective study.
Yes, sir.
No, one. Acha. But we say we have done
So,
or we are doing this.
sorry,
Not
sir, I
like
couldn't hear you.
Okay.
Sir,
Acha, what is the important investigation you should do before phase?
sir,
One.
important investigations
One test.
before doing phase.
Doing phase.
Important test. We have to check the visual acuity of the patient preoperatively, and we should document this.
No.
So, Madhurima, your is orbital complications of phase. You had data of 102 cases.
Yes, sir.
So, was a simple data analysis, or you considered other variables like type of instruments used, or type of anesthesia, or variation in type of infection, bacterial or fungal? Did you consider these variables when you were analyzing this data?
No, sir, it was a simple study.
It was a simple data analysis.
Sir.
Okay, so but do you have any idea of which type of instrument can cause most of the orbital complications?
If we are using microdebrider.
Yes, uncontrolled use of
Yes, sir,
microdebrider,
microdebrider.
uncontrolled use of the suction power. That is the most frequent cause of orbital complications. And do you have any experience regarding surgeries under local anesthesia and phase under general anesthesia in your series?
No, sir, we just
All were under
understood.
general anesthesia, no?
Yes, sir, all are under general.
Was there any difference between bacterial infections, bacterial chronic rhinosinusitis and fungal chronic rhinosinusitis? You added all the cases of chronic rhinosinusitis.
Yes, sir, all the cases.
Was there any difference between bacterial infections and fungal infections regarding these orbital complications of phase?
Sir, fungal disease, it could be invasive, non-invasive, so we have to check preoperatively whether there is any previous orbital involvement or not there. Sir, those are my exclusion criteria.
You excluded all the fungal
Sir,
cases.
orbital, no, sir, orbital involvement, any CRS,
Cases with orbital complications and intracranial complications were
they are
excluded from
excluded.
your study.
Yes, sir.
Okay, thank you.
Okay, sir.
Hello. Our next speaker is Dr. Sushmita Dotto, and our topic is endoscopic repair of spontaneous CSF leaks, our experience.
Good afternoon, respected judges, seniors, teachers, and my fellow colleagues. Today I am going to present a paper on our experiences with endoscopic repair of spontaneous CSF leaks. CSF rhinorrhea is the leakage of CSF through a communication of the subarachnoid space with the sinonasal cavity following a defect in the skull base. Here you can see active leak of CSF. Now, if we look at the literature, we can easily see that spontaneous leaks can be secondary to raised intracranial pressure or normal intracranial pressure. In my study, we have included the spontaneous CSF leaks who had normal intracranial pressure, as they constitute majority of the spontaneous CSF leaks. Aims and objectives of this study were to categorize the patients of CSF leak based on the surgical approach and to measure the outcome in both these groups by periodic follow-up. It was an institution-based prospective study conducted at a tertiary medical institute between January 2020 to February 2022. 10 consecutive cases of spontaneous CSF leaks were included. Patients of CSF leak were selected on the basis of clinical features, biochemical investigations, and radiological findings. And patients with congenital anomalies, coexisting intracranial tumors, and patients who lost to follow-up were excluded from this study. Now, if we look at the age distribution, we had included the patients ranging from 30 years to 70 years in my study, and majority of the patients belong to the age group of 40 to 50. Looking at the gender distribution, out of the 10 patients, 6 were females. Now we conducted investigations for surgical approach of these patients. So first we went for a high resolution CT scan of the nose and paranasal sinuses to delineate the bony defect. As we can see over here, there is a leak in the cribriform plate on the right side. This is also a HRCT of the PNS, which is showing a active leakage of CSF from the left sided cribriform plate. Then we went on for CT cysternography, and here we can also see that there is a defect over here on the right sided lateral lamella. Then MRI was done, heavily T2 weighted with screening of brain to look for further confirm our findings as well as to rule out any other intracranial anomalies, intracranial tumors. All the patients that we had selected for the study had leaks at the cribriform plate, either at the lateral lamella only or lateral lamella and medial lamella, and the size of the leaks were less than 6 millimeter. Now coming to the surgical approach. We first prepared the patient pre-operatively with antibiotics and adequate rest, head and elevation, everything was given. After that, we harvested the thigh fat and fascia lata, which were used as graft materials. Now before I go on to explain the surgical approaches that we used, first I am going to tell you about the two approaches. The first one is when we are going paraseptally and we are approaching first the cribriform plate, we are in head on, we can see the medial lamella. And then if we want to approach, if the leak is in lateral lamella as well as medial lamella, we are resecting the middle turbinate and then we are approaching both of them. This is what we like to call as the narrow corridor approach. Whereas here, as you can see, this is the active leakage of CSF. We are cauterizing the leak. Then it is repaired first with lakes of fat. Then we have to apply Surgicel. We are decongesting with the help of Merosil. Then we will apply fascia lata. So I was saying that after applying the fat that we had harvested from the thigh and Surgicel, now we are using the fascia lata. Again we are going to give another layer of Surgicel and then pack the nasal cavity with non-absorbable nasal packs. Now the layers of graft that we are using, that remains the same in both the approaches. Just the surgical approach is different. The leak site is same. Everything is same. So all the bias is excluded. Just the surgical approach is varying. Whereas in what we like to call as the wide corridor approach, here we have resected the middle turbinate from the axilla. Now we have a wider view of the entire skull base. We are seeing the leak after doing anterior ethmoidectomy, posterior ethmoidectomy, and then repairing it in the same way that we did in the previous approach. We have applied the fascia lata and then finally applied Surgicel. In addition to the surgical approach, we can use some adjunctive measures, absolute bed rest with 30-degree head elevation, IV antibiotics which can cross blood-brain barrier, acetazolamide, monitoring serum sodium and potassium to avoid straining, cough suppressants and stool softeners. We followed up our patients at first at weekly intervals, then at 6 weeks and 3 months. So these are my results at 3 months of post-operative follow-up. If we look at the graft uptake and mucosalization, we can see in the first approach, 4 out of the 5 patients had successful graft uptake and mucosalization, whereas middle turbinate was lateralized in 3 out of those patients. In the wide corridor approach, all the patients had successful leak closure, and mind you, this is at 3 months of post-op follow-up. Middle turbinate was resected in the wide corridor approach, so that's not applicable over here. Now, as we see that there are almost comparable results in both the approaches, but still there are some obvious difficulties which are faced during narrow corridor approach. Manipulation of instruments, identification of the leak during surgery. If there are multiple defects, then it is difficult to assess by using just a narrow corridor approach. Assessment of frontal recess after graft application. There could be stenosis of the frontal recess ostium if we go for a narrow corridor, and surrounding mucosal denudation also becomes difficult. So to conclude, we have to categorize the spontaneous leaks into high pressure leaks and normal pressure. We have to follow it up regularly and always opt for a wide corridor approach because of the obvious difficulties which are faced during the narrow corridor, and also tendency to develop synechia and sinusitis. These are my references. Thank you.
Okay, thank you. Thank you, Dr. Datta.
Yes, sir.
Thank you, Dr. Datta, for your nice presentation. What is the confirmatory diagnosis of CSF?
Confirmatory diagnosis.
Yeah.
So radiological finding we can see, high resolution CT
Any
scan.
laboratory diagnosis? I'm just asking about some.
Lab diagnosis, sir, we can go for beta transferrin, beta trace protein, but it was not done in our case because of its high cost. The patient could not afford it. So we just went for protein, sugar and chloride.
And okay, now coming to the POPA, have you heard the name of empty stellar syndrome?
Yes, sir.
Where does the leak comes?
Sir, at that
in
comes
which sinus it just drains?
Sir, sphenoid sinus.
Yeah.
It's because of the high pressure that the CSF gets collected over the region of the sphenoid sinus.
And if there is a leak in the frontal sinus, I mean lateral part, or the lateralmost part of the sigmoid sinus, is how can you manage actually? Will it be some other, I mean, technique to adapt, or?
Sir, if there is a leak in the
I mean lateral part of the, most lateral part of the sphenoid sinus.
We can go for a, sir, transpterygoid approach.
Full name of that approach? Okay. And what about the frontal sinus?
So frontal sinus, if there is a leak in the roof, then we have to go for a osteoplastic flap technique.
What is the name of that approach? Okay.
So, Dr. Datta.
Yes, sir.
Yours is a operative case series.
Yes, sir.
How many cases were there?
Sir, 10.
10 cases were there actually. What was the commonest age group according to your study?
So 40 to 50.
40 to 50. Does it correlate with the literature review? Spontaneous CSF leak.
Yes, sir. Usually in the 4th to 5th decade, it usually happens.
Okay. Okay. So, regarding your post-operative management,
yes, sir.
I just want to mention, okay, do you find any high flow leak in normal CSA pressure? Can we get some categorization of the rate of flow of leak actually in normal CSA pressure, high flow leak or low flow leak, something like that?
The ICP is normal and still
ICP
there is...
is normal in both the cases, but the rate of CSA flow may vary, even though the intracranial pressure is normal. So that we called normal pressure high flow leak and normal pressure normal flow leak.
Okay, sir.
We should have some little difference regarding post-operative management and also regarding the reparative procedures in the two cases actually. The operative management is not the same in two cases also.
No, sir.
And when you are placing the fascia lata in narrow corridor method,
Yes, sir.
do you take any help of any sort of gel foam or Merocell to place the lata in properly in position?
Yes,
Or
sir.
you did-
We have used Merocils to place it properly at the leak
that
site.
was not shown in your video actually. Yeah, it was directly placed through the narrow corridor, which is very much difficult to place over there appropriately.
Yes, sir.
Okay, thank you.
Thank you, sir.
Our next speaker is Dr. Divya Daga, a riveting case of recurrent rhinosporidiosis.
Good afternoon, respected judges, teachers, seniors, and my dear colleagues. I am going to present a riveting case of recurrent rhinosporidiosis. My patient, a 56-year-old gentleman, non-diabetic, non-hypertensive jewelry maker from North 24 Parganas, presented to our OPD with a huge nasal mass hanging from both nostrils for last 6 months. It was associated with nasal obstruction, bloodstained nasal discharge, and started protruding out from both nostrils. There was also respiratory distress present. There was history of surgery for the nasal mass twice 10 years ago, whose documents were not available. On general examination, he had pallor, clubbing, and bilateral pedal edema. On local examination of the nasal cavity, there was flattening of the nasal bridge. There was a huge fleshy mass, mulberry-like mass, hanging out of the right nostril and protruding out of the left nostril. White spore-like structures were seen on the surface of the mass. The mass bled on touch. Also, on examination of the oral cavity, we saw a fleshy-like mass protruding out and the posterior pharyngeal wall couldn't be seen. After a thorough systemic examination, there was a symmetric finding of the thoracic cage, decreased movement of chest on the left side. There was stony dullness on percussion, and on auscultation, we saw a decreased vesicular breath sounds and a decreased vocal resonance. We performed all the basic preoperative radiological and pathological investigations. The chest X-ray showed us a left-sided massive pleural effusion. A referral to the chest medicine department was made, pleural tapping was done, and 1.5 liters of pleural fluid was tapped out and sent for cytology, LDH and protein, malignant cells, and adenosine deaminase. The pleural fluid analysis turned out to be of exudative type with increased adenosine deaminase and negative for malignant cells. Also, the sputum for acid-fast bacilli came negative. With the help of chest medicine department colleagues, he was clinically diagnosed as pulmonary tuberculosis, and he was started on antitubercular treatment since then. We also performed this contrast-enhanced CT scan of nose and paranasal sinuses, showing the mass involving the whole of the right nasal cavity and part of the left nasal cavity, extending beyond the corona and obscuring the whole of the oropharynx. Now that we have put all the parameters, now let us put some important points in the table before proceeding with the management of this case, as this was not a usual presentation of rhinosporidiosis. Our patient had a huge nasal mass with pulmonary tuberculosis with respiratory distress but no stridor. It had difficulty airway for intubation following anticipation of huge intraoperative blood loss, and he was declared unfit for any surgical interventions. It was a dilemma what to do next with the management for this patient, As the mass was rapidly progressive in nature and there was increased respiratory distress, we formed a multidisciplinary task committee comprising of the Department of Chest Medicine, Anesthesiology, and Otorhinolaryngology. Decision of early surgical intervention under general anesthesia within 7 days of start of antitubercular treatment was finalized. Elective tracheostomy was planned as endotracheal intubation was not possible. It included the surgical excision of the entire mass followed by cauterization of the bases. Intraoperatively, there was a large feeding vessel which was identified. The mass was involving the oropharynx with the involvement of tonsillar pillars as well as soft palate. These multiple site involvements were the major hindrance in the excision and it made the surgery complicated. Also, the use of bipolar diathermy for cauterization was a challenge in itself. The sample was sent for the evaluation of histopathological examination in formal saline and normal saline. Immediate postoperative period was uneventful and the patient is on regular follow-up with chest medicine and otorhinolaryngology OPD since then. This is the histopath image showing us the red arrow is a mature sporangium and the green showing the endospores. With this, the diagnosis of rhinosporidiosis was confirmed. Now there must be a question in everyone's mind that why am I presenting such a common case in this clinical meeting? Actually, after a thorough literature research in the PubMed Medline database with keywords like nasal, rhinosporidiosis or recurrence, there were showing 319 results, of which only 2 case reports were of recurrence. Considering the fact that this being such a common entity and everyone present here is very much aware and continuing this treatment of this disease may be one of the reasons for the underreporting as well. In fact, the literature review revealed our case to be the largest nasal rhinosporidiosis mass, that is 14 centimeters, to exist and to be reported today. Owing to the larger size of the mass with associated comorbidities, this case posed to be a surgical challenge. Rhinosporidiosis is a chronic granulomatous disease caused by Rhinosporidium seberi, an aquatic mesomycetozoa affecting both man and animal. It is limited to the mucosal epithelium and infection is from local traumatic inoculation. It involves the nose, nasopharynx, followed by palpebral conjunctiva along with lacrimal apparatus, also mouth, upper airway, eye and genitals. The risk factors include rural residence, farming, bathing in ponds, working exposure to stagnant water. The disease is non-amendable to medical therapy. It shows high recurrence rate, requiring patient to undergo multiple surgeries, often resulting in increased mortality. Dapsone plays a controversial role in the treatment of the disseminated rhinosporidiosis to prevent the recurrence. The disease is mainly reported from India and Sri Lanka. In India, it mainly involves Tamil Nadu, Kerala, West Bengal, and Chhattisgarh. Now to conclude, a recurrent case with a huge nasal mass involving the nose, nasopharynx, and oropharynx, we must look for other anatomical sites and perform a thorough systemic examination. As in our patient, there was no involvement of eyes, larynx, but he had tuberculosis, so it was a big dilemma for us, which to be treated first. Not all rhinosporidiosis mass has a mulberry-like look. As in our patient, the oropharynx involvement did not have a white spores present. So, in any mass in the oropharynx, rhinosporidiosis should be excluded out. With the help of multidisciplinary task committee, we plan our management. It should be treated as early as possible to prevent further systemic complications. These are my references. Thank you.
Thank you. Thank you, Dibba. It was a really nice case to be present in the audience. Rhinosporidiosis is notorious for recurrences.
Yes, sir.
Actually, I have seen case. I have done thrice. I have operated thrice on the same patient in a span of 5 years, and I'm sure the audience, most of them have similar experiences. Anyway, nowadays, actually, that time, what precautions do we take while operating first time in a case of rhinosporidiosis? I mean, surgical precautions, surgical expertise.
Sir, to prevent the recurrence,
Yeah.
we do the cauterization of the base. And since in our, we should technically use cobblator technique, but we use diathermy. That was again a challenge for the procedure.
Okay. And only electrocautery.
So,
Electrocautery.
Yes, sir.
No laser, nothing.
So laser coblation technique, we can
Okay.
use laser as well.
Have you used Dapson? Actually, it was used previously.
Sir, actually, according to the recent studies, initially it was Dapson was used for the to prevent recurrence, but according to the recent data, Dapson is not that used in the treatment of the recurrence. It plays a controversial role. So nowadays we do not give Dapson.
Okay.
Dr. Daga, in your cases and regarding the references
Yes, sir.
from literature review, do you find any correlation between tuberculosis and recurrent rhinosporidiosis?
No, sir.
There was no such correlation.
No, sir.
So what was typical for this case?
Sir, the major hindrance for our case was the patient had tuberculosis, and specifically to be pulmonary tuberculosis. So that was the one thing before operating we had to clear it out, and the patient was started on anti-tubercular drugs following.
So rhinosporidiosis has nothing to do with the immune status of the patient?
No, sir, it is. The recurrence which takes place, it's basically because of the
Yes, that's why
cell-mediated immunity. The recurrence which happens is because of the reduce in the cell-mediated immunity.
Maybe.
Yeah.
It's not proven.
Yes,
actually.
sir. The studies shows that.
In your case, could you localize the base of the lesion actually? From where it did started?
Sir, according to the protocol, where we need to excise the mass completely. As long as we can see the mass, we'll excise it, followed by cauterization.
How rhinosporidiosis progresses or recurs?
Sir, with the submucosal spread via lymphatics.
Submucosal spread. So for
Via
that it needs wide cautery of the base. And anything else? It also spread through shedding actually. Shedding to other cut mucosal areas. For that you have to go for constant saline irrigation of the surrounding areas so that there is no such incident happen to prevent recurrences. Okay, good case. Thank you very much.
Dr. Poroma Mukherjee. Thank you. Hello. Dr. Poroma Mukherjee. Her topic is unusual case of parotid duct silolith. Dr. Mukherjee.
Good morning, good afternoon, respected judges and the august audience. I am Dr. Poroma Mukherjee, and today I am going to present a case report on an unusual case of a parotid duct silolith. Before we start discussing the case, we would quickly go through what a silolith is and how it is formed. A silolith is a calculi in the ductal system of salivary glands, and 80 to 90% stones develop in the Wharton duct, while only 10 to 20% of them form in the Stenson or the parotid duct. 1% are seen in the sublingual duct, and silolith is seen more commonly in men. The incidence of silolith is about 1 in 10 to 30,000 of the population, out of which 10 to 20% are in the parotid. Therefore, only 1 in 1 lakh to 3 lakh cases are seen. Salivary calculi are composed of calcium phosphate and carbonate in combination with an organic matrix of glycoprotein and mucopolysaccharides. Small amounts of salts such as magnesium, ammonium and potassium are also seen in the stone formation. Mechanism of silolith formation. Salivary stasis and inflammatory changes play important key roles here. Intermittent salivary stasis, alteration of the mucoid elements of saliva leading to the formation of framework of an organic gel where there is deposition of salts leading to calculi formation. This process is seen more commonly in the submandibular gland. In the submandibular gland, development of a silolith might be the primary event that results in stagnation of saliva and inflammation, which encourages retrograde bacterial migration that can result in sialadenitis. Now the case. This is a 56-year-old non-diabetic hypertensive female who presented with chief complaints of intermittent pain over the left side of the cheek for the last 5 years, associated with salty secretion in the mouth, which was intermittent, and it has recently exacerbated over the last 1.5 years. It was also noted that after the release of salty secretion, the pain over the left side of the cheek subsided. Now we'll come to the examination bit. On clinical examination, we could not palpate the stone on bimanual palpation of the Stenson duct, and also there was no swelling over the parotid gland. So now what next? We went for an USG where we could see a stone of 3.5 millimeter diameter, which was in the parotid duct lying 2 centimeter away from its opening into the oral cavity. We then went for a CT scan where we saw a 3.5 millimeter hyperdense silolith in the left Stenson duct 2 centimeter away from the opening into the oral cavity. The surgical plan. We went for an open approach where we made a modified Breyer incision and raised the flap anteriorly to locate the buccinator and palpate the duct. After palpating the duct bimanually, we located the stone, and distal to the stone we placed a stay suture which would prevent the slippage of the stone. After that, we made a small nick just above on the duct wall overlying the stone, and we delivered out the stone. After that, we sutured the duct wall. We gave extra mucosal sutures using 5-0 Vicryl. Here we can see that in the first diagram, we have placed a stay suture just distal to the stone. This is the silolith. And in the third diagram, we are seeing that I'll show you the video. Here we are checking for the free flow of normal saline through the Stenson's duct after the stone was delivered out. And we can see that the parotid duct is patent. This is also helping in irrigation of the duct. The incidence of sialolithiasis is less common in parotid gland due to low salivary viscosity, higher protein levels, and the downward course of the Stenson's duct, which is not against the gravity. The methods of treatment can be conservative or surgical. Conservative include oral analgesia, hydration, local therapy, and sialogogues to promote ductal secretion. Endoscopically assisted technique for the retrieval of parotid siloliths is a gland protector method, and the success rate is high and post-operative complications are low. Interventional sialoendoscopy is successful for siloliths that is mobile and less than 5 millimeter. Open surgical treatment include transoral ductal incision, external approaches, or a combined venture. In this case, we went for an open approach due to lack of a sialoendoscope in our setup. Also, on clinical examination, we could not bimanually palpate any stone. Now, why is this case uncommon? The Wharton duct or the submandibular duct is longer, wider, more tortuous, angulated against gravity unlike the parotid duct, as it courses around the mylohyoid muscle. Now all these contribute to slower salivary flow rates and consequently poor salivary egress into the oral cavity, thus promoting stasis. The saliva produced by submandibular gland itself is more viscous and has a higher calcium and phosphorus concentration. Inflammational ductal injury to the parotid gland from chronic sialadenitis is believed to be the inciting process for sialolithiasis. We can conclude Stenson duct sialolithiasis is a rare salivary disorder. The exact etiology is still obscure. Treatment depends on the size and location of the calculi. With the advent of sialoendoscope, it has become easier to manage sialoliths, and the intraoperative care has to be taken to prevent complications like facial nerve palsy, salivary fistula, and sialocele. These are my references. Thank you.
Thank you, Dr. Poroma. It was a nice presentation.
Thank you, sir.
Two questions. Just can you tell me the opening of the Stenson duct?
So the Stenson duct opens just above the second upper molar tooth.
Number one. Acha. Is parotid, parotid duct ciliate always radio opaque?
No, sir, it can be radiolucent as well.
Why it is radiolucent sometimes?
Sir, depending on the composition of the salt, it may be radiolucent. And in that case, detecting the sialolith radiology can be difficult. So we can go for a retrograde sialogram to locate the stone.
There are a lot
or
of other
digital subtraction sialography. Yes, sir.
Okay.
Thank you, sir.
Paroma, can you show the CT showing the stone?
Yes, sir.
Okay, it is nearer to the opening.
Yes, sir.
Still, it was not bimanually palpable.
Yes, sir.
What was the size of the stone?
Pardon, sir?
Size of the stone.
So it was 3.5 millimeter.
3.5 millimeter.
Yes, sir.
Okay. And how do you identify Stenson duct during open surgery?
So we know the course of the Stenson duct. It leaves the parotid gland superficially and it lies along the masseter and it enters the buccal pad of fat from the anterior border of the masseter. So we can palpate it there, and then it pierces the buccinator, and between the buccinator and the saliva, the mucosa, it enters the oral cavity.
So it is sufficient to identify the duct during surgery.
Sir, we also have to take care that we do not damage the buccal branch of the facial nerve which lies in close proximity to the duct here. So that has to be kept in mind as well.
You had nerve monitor in your OT?
No, sir, we did not.
Okay, thank you.
Thank you, sir.
Thank you, Paroma.
Thank you, sir.
Before our next speaker is Tiyasha Noshkar, and the topic is surgical outcome of tracheostomy using conventional and Bjork flap techniques, a comparative study. Before asking Tiyasha to start, there is a small announcement. The registration for MidIcon is going on, and our office assistants are staying. They are doing the registration. All are requested to please have the registration done. Please. And now, Tiyasha, your time.
Good afternoon, respected judges, my seniors, teachers, and my dear colleagues. Today, I'll be presenting a comparative study between the surgical outcome of tracheostomy using the conventional method and the Bjork flap technique. Tracheostomy is a surgical procedure of making an opening in the anterior wall of the trachea and converting it into a stoma on the skin surface. And the indications of tracheostomy are respiratory obstruction, retained secretions, and respiratory insufficiency. Here in this diagram, we can see the position of the patient and the methods and the steps of doing the conventional tracheostomy. Now the incisions used in tracheostomy. Removal of small anterior portion of the tracheal rings create a tracheal window, which is a more permanent kind of stoma. But other type of tracheal incisions can also be used, like inverted U-shaped, I-shaped, horizontal, T-shaped, box, H-shaped, cruciate, or U-shaped. Now we'll talk about Dr. Ernst Bjork from Sweden, who was a professor of orthodontics in the Royal Dental College. He introduced the Bjork flap in the year 1952. Now Bjork flap, it is an inferior base tracheal flap where a 4 to 5 millimeter wide inverted U-shaped incision is made through the third and the fourth tracheal ring, which is later fixed to the skin to secure the tracheostomy lumen. It is more likely to be done in patients with elevated BMI and in patients who would require prolonged ventilation. In this diagram, we can see the Bjork flap technique. Here in this video, we can see that after local infiltration is done, we are making a midline incision starting from the cricoid to the sternal notch. And after that, we dissect layer by layer, making sure we stay in the midline to
expose the trachea, and after the trachea is exposed, we make the inverted U-shaped incision. And after the tracheal opening is achieved, we put the tracheostomy tube, inflate the cuff to make sure the patient is well ventilated, and after that we hold the flap using Alice tissue forceps and secure by suturing it to the chest skin using Prolene suture material. In this next diagram, we can see the steps of performing the Bjork flap technique, and the last diagram shows the stoma being formed after 3 weeks of surgery. Now we'll come to our study. The study period was from January 2021 to May 2022 in a tertiary care hospital of Kolkata with a sample size of 70 patients aged from 4 to 75 years. Block randomization was done to select the patients, and patients are being followed up for 1 year. Now the exclusion criteria from our study was deviated trachea, neoplasm on the tracheal walls, and intraluminal growth. Now for the results and analysis, we will divide the patient in 2 groups, each consisting of 35 patients, where the first group underwent the conventional method and the second group underwent the Bjork flap technique. Here we can see that out of the 70 tracheostomies that we performed for our study, 51.4% were performed as emergency tracheostomy, whereas 48.6% were performed as elective tracheostomy. 71% of our study population was male, and in this age distribution bar diagram, we can see the minimum number of patients belong in the age group of 4 to 10 years, and the maximum number of patients belonged in the age group of 61 to 75 years. Now we'll talk about the time required to establish the airway. Here in this chart, we can see that almost same time is taken in majority of the cases in both the techniques to establish the airway, and the average time taken is 4 to 8 minutes. Now the post-operative complications. The most common post-operative complications for tracheostomy are peristomal granulations, surgical emphysema, stomal stenosis, post-operative dysphagia, secondary hemorrhage, etc. Here we can see that peristomal granulation, stomal stenosis, and secondary hemorrhage were not seen in any of the patients who underwent the Bjork flap technique. And 91% of the Bjork flap technique patients presented no complications post-operatively. Other serious complications of tracheostomy include air embolism, tracheoesophageal fistula, but luckily we did not encounter any of these complications in our study. Now the complications associated with decannulation. Here we can see that the 80% of the patients who underwent the Bjork flap technique and were decannulated, they healed within 1 week of decannulation, and none of them developed tracheocutaneous fistula post decannulation. However, we can see that tracheocutaneous fistula formed in 6% of the patients who underwent the conventional method tracheostomy. Now we'll discuss the advantages of Bjork flap over the conventional method. As a surgeon's perspective, we can see that the time required for the airway establishment is almost same as the conventional method, and the learning curve is also easy. And also tube change stomal care are also easy, and there is almost always successful decannulation without tracheocutaneous fistula formation. The Bjork flap, it provides a bridge of tracheal conduit that guides the tracheostomy tube, thus we can avoid creating a false passage, and thus it is safer to use. And the excision type window which we use in conventional method can produce transverse tears in the early tube replacement, and therefore there is chance of closure by scar tissue in long follow-up. Now the disadvantages. In elderly patient, there are chances of cartilage injury due to ossified tracheal rings. In pediatric age group, there are chances of injury to adjacent structure due to their small tracheal luminal diameter with soft cartilages. Bjork flap technique is difficult to perform on previously irradiated neck due to thickened skin and subcutaneous tissue. Retropulsion of the flap during tube replacement may cause dangerous obstruction, but this complication is rather theoretical. Now to conclude, tracheostomy is an emergency life-saving procedure routinely practiced in ENT setup, and Bjork flap is one of the modifications of incisional tracheostomy with lesser complications, thus it requires lesser post-operative care. And one of the most common causes of tracheostomy is stridor due to malignancy. But in case of laryngeal carcinoma, it is not wise to perform Bjork flap. However, there is no such contraindication for the conventional technique to be done. And the safety of Bjork flap is mostly studied in cases of elective tracheostomy. However, at the end, the surgeon's preference and the indications play the major role to choose the surgical method we use for the tracheostomy. Here are my references. Thank you.
Thank you, Tiyasha, for this good presentation. Did you do yourself this Burford technique, or you have seen only?
Sir, I myself have not performed the Bjork flap technique. I have performed using the conventional method.
Technique. Achha.
Yes, sir.
Now, you have seen
Yes,
being
sir.
done
Yes,
at
sir.
your hospital.
Yes, sir.
Achha. So, what is the suture material? What is the suture material?
So we generally use Prolene to secure the flap to the skin.
Prolene.
Yes, sir.
Are you sure?
So yes, sir.
And from the flap, which structure do you stitch? I mean, is it a skin or cervical fascia like that?
Sorry, sir.
One from the flap and one from which part of either is the skin or the cervical fascia like that?
So the skin over the chest one.
Another thing is, for a first year resident, which one will be easier, a conventional technique or a Bjork flap technique? Because
So we are more used to perform the conventional method in our day-to-day setup. So we are more comfortable with doing that.
okay. Regarding suture material, please have another look, because what we know, I think it is Vicryl. I think I am requesting the audience.
Okay.
It is mostly Vicryl 30,
Okay.
most likely.
So, Tiyasha,
Yes, sir.
so in your presentation,
Yes, sir.
are you putting this York method as a better alternative or just as an alternative method?
Sir, there are pros.
In general.
Yes, sir. We have seen that there are advantages of doing Bjork flap since there are very less instances of stomal stenosis or peristomal granulation. But sir, in our tertiary care setup, we mostly get patients who present with stridor due to malignancy. But we cannot perform Bjork flap if there is growth inside the lumen or deviated trachea.
So there are some specific indications.
Yes, sir.
To prefer York technique.
Yes, sir.
You have mentioned it.
Yes, sir.
Prolonged ventilation.
Prolonged ventilation, increased BMI, sir, high BMI patients.
High BMI.
Yes, sir.
But you have chosen a age group of between 0 to 4 years.
So
Is it
4
so?
to 10 years.
4 to
Yes,
10
sir.
years. Why you have chosen this age group for this York method? In your age distribution, there were some population
Yes, sir.
in the age group of 4 to 10 years. What was the indication of adopting this method in this age group? Was it just for a comparative analysis or something else?
Sir, we chose pediatric patients who would require prolonged ventilation. Like, sir, there were patients who were victim of road traffic accidents, sir, so requiring.
Then it's okay. Then it's okay.
Yes,
Okay. So, can you mention the size of the tracheal flap in those patients in the age group of 4 to 10 years of age? That should not be that adult size
no,
that
sir.
you have
For
mentioned.
the pediatric population, the flap size has to be small because their tracheal cartilages are not ossified and the lumen is also small.
Okay.
And so there is chance of devascularization if we choose a very large flap and flip it outwards and fix it to the skin.
What could be the better tracheal incision shape in this age group? 4 to
Sir,
10?
cruciate.
Crisscross.
Crisscross, cruciate.
Okay.
Yes, sir.
So, regarding decannulation,
Yes, sir.
do you find any procedural differences between decannulation in conventional method and decannulation in York's flap method?
So we had some patients who presented with tracheocutaneous fistula and who underwent the conventional method. Yes, sir.
Okay, thank you.
Thank you, sir.
Our last speaker is Shutarthi Kaur, and his topic is variable presentations of benign spindle cell neoplasm in head and neck.
Good afternoon, respected judges, my respected teachers, my seniors, and my dear colleagues. I am going to present a case series on variable presentations of benign spindle cell neoplasm in head and neck region. So spindle cell neoplasm defined as neoplasm that consists spindle-shaped cells with elongated nucleus arranged in palisading manner in wavy pattern in histopathological examinations. These lesions can be highly variable in biologically and clinically. The most common presentation site for this lesion is parapharyngeal space, and oral cavity is a very rare presentation site. So studies have shown that a head and neck region is the site of origin in most of all solitary spindle cell neoplasm of neural origin, and they are mostly presented in the lateral part of the neck. We are presenting a case series of 5 cases of various mode of presentation of benign spindle cell neoplasm that came under medical supervision in Kolkata Medical College and Hospital in the time span of May 2021 to June 2022. Our first case is a 42-year female patient who came with a slow-growing deep-seated mass in the left cervical region for last 1 year and foreign body sensation in throat for last 2 to 3 months. In clinical examination, we found a single solitary lesion in left cervical region extending from the lower border of mandible to the junction of the upper 1/3 and lower 2/3 of the anterior margin of sternocleidomastoid. It was spherical in shape with rounded margin, and it was not adherent with the overlying skin. Oral examination revealed a mild bulging over the left posterior tonsillar pillar. An indirect laryngoscopy revealed bilateral mobile vocal cord with no compromisation of the airway. MRI showed a T2 contrast enhanced homogeneous mass in the left parapharyngeal space, which was free from all underlying structures, and it was showing a splaying of the left carotid bifurcation in the MR angiogram. The surgical excision done of the mass through the transcervical route, and the histopathological examination was showing the suggestive features of neurofibroma. Our second case is a 23-year female patient who presented with a swelling in the floor of the oral cavity in the left side of her mouth for last 1.5 years, which was initially small in size and started growing in size for last 6 months. On clinical examination, we found a globular firm to hard mass which was extending from the lingual frenulum to 2 cm to the left of the oral cavity. There was no restriction of the tongue movement. In MRI, we found a solitary T2 contrast enhanced mass in the left side of the oral cavity, which was free from all underlying structures. Surgical excision was done, and histopathological examination was suggestive of schwannoma. Our third case was a 35-year female patient who came with the complaint of a stucking sensation during swallowing for past 6 months. On clinical examination, we found a smooth globular mass to hang from the posterior midline of the soft palate replacing the uvula. On probing, it was firm, non-tender and adherent to the lower 2/3 of the uvula. Surgical excision was done, preserving the upper 1/3 of the uvula and complete removal of the mass. Histopathological examination was suggestive of schwannoma. Our next case was the 37-year male patient came with the complaint of slowly growing swelling in the right side of tongue for last 1 month. On examination, there was 1 into 1.5 centimeter mushroom-like polypoidal growth, which was pedunculated, firm, non-tender and non-ulcerative. Complete surgical excision was done, and histopathological examination was suggestive of neurofibroma. Our fifth case was a 67-year female patient who came with a neurofibromatosis type 1, who presented with progressive hoarseness and dysphagia for last 6 to 7 months. Fiber optic laryngoscopy revealed a smooth globular swelling involving the left AE fold, partially compromising the airway and obscuring the ipsilateral pyriform fossa. CECT showed a homogeneous mass in medial wall of left pyriform fossa extending caudally beyond the level of glottis. Microlaryngoscopic examination done to confirm our finding, as well as submucosal resection of the mass. Histopathological examination was suggestive of neurofibroma. This is our summary of the 5 cases. We have examined 1 male and 4 female patients in the age span of 23 to 67 years. 3 of them was finally diagnosed with neurofibroma and 2 of them was finally diagnosed with schwannoma. So spindle cell neoplasm can be differentiated into various types according to their cell of origin, and but we found all of our cases of neural origin which can be further differentiated into neurofibroma and schwannoma, which can be presented as extracranial solitary well demarcated lesion in head and neck region. This can cause various secondary symptoms like dysphagia, hoarseness, etc. depending on their location. Imaging modalities and FNAC is of very limited help in diagnosis due to their variable presentation and very limited amount of tissue for biopsy. So final diagnosis is always done by the post-surgical histopathological examination. These lesions can present as either benign or malignant lesion in head and neck region. As our first case, left parapharyngeal swelling, which was finally diagnosed as neurofibroma, was initially mimicking a carotid body tumor as it was showing a splaying in the carotid bifurcation in the left side, and there was a Lier sign positive in the MR angiogram. But indicating towards our final diagnosis, there was a cafe au lait spot present in the left side of the patient's neck, and the typical saltpeter appearance of Lier sign was absent in this case. Our second case, the floor of mouth swelling, was initially mimicking monosalivary gland neoplasm with the short history and the firm to hard consistency of the mass. It was finally diagnosed as schwannoma, and indicating towards a benign lesion, this mass was free from all the underlying structures. Our third case, the uvular swelling, initially we thought of the differential diagnosis as angioneurotic edema, mucocele or dermoid due to the site of origin, but it was finally diagnosed as schwannoma. Our fourth case, the papillomatous growth in the tongue, initially thought to be hemangioma due to the site of origin and huge bleeding on excision, but it was finally diagnosed as neurofibroma. And our fifth case, the differential diagnosis we thought is first the differential diagnosis was A-fold neoplasm due to the age of patient, chronic smoking history, change of voice and dysphagia, but the second differential diagnosis was neurofibroma as the patient had neurofibromatosis type 1, kyphoscoliosis, and neurofibroma is very common in the laryngeal region. In our study, we have found 3 cases to be originated from the left side of the body, one in the midline and one in the right side of the body, but the nerve of origin could not be specifically identified. So in conclusion, we can say that the extralaryngeal spindle cell tumors of neural origin often present as asymptomatic solitary masses. Preoperative diagnosis can be difficult. These lesions can mimic the other benign or malignant lesions in the head and neck region. So the appropriate approach of treatment should be the surgical excision depending on the thorough clinical investigation and clinical suspicion and the clinical history present. But always we should keep in our minds that there can be an underlying chance of nerve injury. So we should expect the unexpected, and we should keep our mind ready for unexpected consequences. These are my references. Thank you, sir.
Thank you, Sudharthi, for your excellent presentation. Really a nice one. Actually, benign growth in head and neck region is very rare regarding spindle cells. Benign spindle cell growth, in which organ it is commonest in the body?
Sir. Because
most of the spindle tumor are malignant in head and neck most of the time.
Yes, sir.
You will get very few benign growth.
Yes.
But can you name an organ which mostly has benign spindle growth? Okay, I will tell you later on. And what is the take-home message for us after operating these patients? Do you plan for keeping mind in that malignancy may happen? Any take-home message for the patients? The follow-up, regular follow-up, or like that something.
For these cases, sir.
Yeah.
Sir, actually, this is for the surgical approach I have presented that we should, these cases were mimicking the other benign cases or the malignant cases. So if we are thinking of some differential diagnosis, we should keep in mind that this can be a diagnosis, and each as it is only can be diagnosed by after the post-surgical histopathological examination. And in case of neurofibroma, we can injury the underlying nerve, so we should be always cautious, and we should look for the other clinical history or the history in family or the other features in the clinical part.
Okay.
So that we can
Okay.
So, Sudarthi, you presented 5 cases
Yes, sir.
series. So, all of them are of neural origin.
Yes, sir.
No single cases are of epithelial or odontogenic origin.
Sir, in my series, I wanted to show the various different origins, various different presentation of the cases, and we found all of them from neural origin only in the histopathological examination.
So can it be of any analytical value that all the 5 cases are of neural origin? In
sir,
the oral cavity and head neck, we have plenty of other sites
sir.
where we can see the
Yes,
spindle
sir.
cell tumors.
Yes, sir.
Mostly epithelial sites and odontogenic sites.
Yes, sir.
But all of your cases are of neural origin. Can it be of any analytical value?
Sir, in my case study, it don't have any analytical value that much, because we are not, haven't that much number of cases for the analysis. We can say that is the ratio of different origin of cases.
Okay, are all those cases were encapsulated tumors?
Yes, sir.
Even the neurofibroma also?
The parapharyngeal neurofibroma was encapsulated one, but the laryngeal origin was the submucosal dissection, that I cannot comment on that.
Okay. So you didn't go for any histochemical staining actually?
Yes, sir.
Histobiochemical staining, you didn't go for it?
Yes, sir. Which one, sir? All of the cases we did not went for the histochemical
staining actually.
staining. The first one, the parapharyngeal case, we did histochemical staining, sir.
What was the positive stain actually?
Sir.
Of neural origin or neural filament origin, something like that actually. Certain, that should be positive for certain stains actually. Huh?
Sir, there should be this in histopathological examination. We
Not
should
histopathological,
histochemical, sir.
Immunohistochemical staining.
Yes, sir. Sir, the exact one I
Okay.
could not.
Thank
Hello. Thank you. I will take only 5 minutes. Okay. First of all, that thank you all of you for coming to this clinical meet AOI West Bengal. Now I will ask the participants. All of you have excellently presented. The first, the sponsor talk, the Misbah, Dr. Misbah ul Haq will come and he will receive the certificate from the judges. Dr. Bora sir, Vidhanda, please come to the stage. Shubhajit da. Shomen sir, please come. You also come now, you are the head of the department. Come. The first certificate, Misbah ul Haq. দেবু ছবি তো বিধান দা এদিকে চলে এসো, এখানে দাঁড়াও না। Second one, Dr. Shutirtha Saha from NRS Medical College. He will receive the certificate from the judges. Dr. Madhurima Mondol from Arjikar Medical College. She will also receive the certificate. Dr. Shushmita Datta from Arjikar Medical College. Dr. Divya Daga from Kolkata Medical College. Dr. Paroma Mukherjee from Kolkata Medical College. Dr. Tiyasha Noshkor from Kolkata Medical College. And Dr. Shutarthi Kaur from Kolkata Medical College. Thank you, and just stay for 2 minutes. I will ask Shomen sir to say something.
Dr. Kailash Prasad Verma is here to invite you for the Mid-AOI-Con. I would request Dr. Verma to invite you.
Respected seniors and colleagues, I am very honored to have given responsibility to organize 13th Mid-AOI-Con at our hospital, Central Hospital, Southeastern Railway. It's a beautiful location, and we have recently purchased high-end image-guided navigation system, then high-end Carl Zeiss microscope. So it will be feast to watch the surgery, live surgical workshop, and there will be academic sessions also. So with folded hand, I request invite all of you to participate in a big numbers. And online registration is on. Offline we can register from CMC house, or it is going on here. So please participate in more and more numbers. Thank you very much. Faculty is Dr. Deepak Dalmia and Dr. A.K. Malhotra. Dr. Dalmia is a national faculty. He is yes. Dr. Dwarkanath Reddy will be deliver oration. Thank you very much.
So we will be meeting again at Mid-AOI-Con at Garden Reach.
20 and 21st August.
Yes. And now I would request Dr. Amitabh Rai Chaudhuri to announce the program at VIMS.
Thank you, Professor Bandyopadhyay, for allowing me to be here. I take this opportunity to invite you all to my institute, Vivekananda Institute of Medical Sciences, this year for our annual workshop, which we have not been conducting for last 3 years due to COVID and various reasons. This year the workshop we have planned on 14th and 15th of October, which is Friday and Saturday. First day will be live surgery as we have done in the past, but it will be only ear surgery, and day 2 will be temporal bone, wet temporal bone dissection hands-on course. And the theme of this year's workshop will be surgery, which is atresia and microtia surgery, and we have invited Dr. Ashish Bhumkar, who has made a reasonable mark in the country and Asia also for this surgery in the recent years. So he will be demonstrating the surgery for microtia and those kind of pinaplasty and those surgeries. So please join us, and the brochures and information will be in the air and to your doorstep very soon. Thank you very much. Please come and join us for this work.
So we'll be looking forward to the excellent program that always VIMS presents us. Now I would request Dr. Soikat Samadar, who is here from Institute of Otolaryngology and Head Neck Surgery, IPG MER, to invite us for their program.
Thank you, Shoman sir, for allowing me to speak. Good afternoon, respected delegates, members, my seniors, juniors, colleagues. We from IPG MER would take the privilege of inviting you to the Advanced Lateral Skull Base Surgery event, where Dr. Satish Jain will be coming and demonstrating over 2 days the lateral skull base on cadaver, and also live surgical sessions will be there. Day 1 is, as sir has proposed, day 1 will be properly dedicated to cadaveric dissection, which sir will do and demonstrate before us. And on day 2 we will have extensive surgical cases. Till now we have cases like glomus tumor, acoustic neuroma, petrous apex cholesteatoma, temporal bone carcinoma. Let us see how much we can deliver. Sir will be there for the full 2 days, so it will be a grand event, but the event will not be grand without your participation. We are looking forward to meeting you all on that very 2 days, the 24th and 25th of September 2022. Those are Saturdays and Sundays. Please block your dates on those 2 days and make yourself available. Thank you so much.
Okay, now I will request Dr. Deeptangshu Mukherjee to deliver the vote of thanks.
Thank you. Thanks to all of you for attending this clinical meeting. I want to ask anybody from the Lupin, do you want to, because they are sponsoring the event, for that reason, do you want to say something from your side? Thanks to our secretary, our president, everyone from the other institute who have come and joined this clinical meeting.
So thank you so much. In future also we wish to participate with AOI. This is the first time we have participated. So thank you so much, and thanks for cooperation. Thanks to you also, sir. Thank you so much.
Thank you. Now this is the end.